Welcome back to the deep dive. Today we're tackling a topic that is incredibly common but also notoriously complex. Heart failure.
Sometimes still called congestive heart failure or CHF.
Exactly. And if
Mhm.
you've ever felt a bit lost trying to figure out, systolic versus diastolic or why the body seems to sabotage itself in the process, this deep dive is for you.
That's our mission, really, to
Yeah.
get past just the symptoms and clarify the root pathophysiology. We're going to look at how the body's own compensation backfires.
And then map out the complications and finally get into the modern multi-drug approach to managing it.
Right.
Okay, so first things first. Heart failure isn't a heart attack.
No, not at all. A heart attack can cause heart failure, but they're different things. Heart failure is just when the heart can't pump enough blood to meet the body's needs.
And we're mostly focusing on left heart failure today, but we'll touch on right heart failure.
And the real strange one, high output failure.
Okay, let's start with that crucial divide in left heart failure. It seems everything hinges on whether the heart is struggling to pump or struggling to fill.
It's the fundamental question. Both lead to low cardiac output, but the heart looks and acts completely differently in each case.
So what's the first flavor?
Let's start with a classic, systolic heart failure. Clinically, you'll hear it called HFrEF.
HFrEF, heart failure with reduced ejection fraction.
Exactly. The diagnosis is made when the left ventricular ejection fraction, basically the percentage of blood pushed out with each beat, is less than 40%.
So this is the forward flow problem. The muscle is just too weak. I've heard it described like a stretched out water balloon.
That's a perfect analogy. It's big, it's dilated, it holds a lot of blood, but it just doesn't have the squeeze, the contractility to push it forward.
And what causes that weakness?
Usually it's damage. Scar tissue after a big heart attack, myocardial infarction, or it could be something like a dilated cardiomyopathy where the walls are just genetically thin and weak.
Okay, so that's the weak, flabby balloon. What's the other side of the coin?
The other side is diastolic heart failure, or HFpEF.
The P is for preserved ejection fraction.
Right. If the systolic heart is a weak balloon, the diastolic heart is like a thick, rigid, concrete bunker.
So it can squeeze just fine. The pump works.
The pump works great. The ejection fraction is preserved, usually over 40%. The problem isn't pumping, it's filling. The ventricle is so stiff it can't relax and take in enough blood.
So the tank is half empty before it even tries to pump. What makes the heart build itself into a concrete bunker like that?
It's almost always a response to long-term high resistance, high afterload.
Like high blood pressure.
Chronic uncontrolled hypertension is the #1 cause, or something like aortic stenosis, where the valve is really stiff. The heart muscle has to work so hard to push against that resistance that it hypertrophies, it gets super thick.
So the body's attempt to get stronger to overcome the pressure is actually what causes the failure down the line.
It's the ultimate self-sabotage. That thickened wall, the hypertrophy, literally shrinks the inside of the chamber. There's less room for blood, and it's so stiff that it takes huge pressure just to fill it up a little bit.
Incredible. So one is a weak pump that can't push, the other is a stiff pump that can't fill?
That's the distinction.
Yeah.
And it's vital for treatment.
Okay, so regardless of the cause, the immediate result is low cardiac output. And that low CO is what triggers the body's self-destructive panic mode.
This is the vicious cycle. This is what makes heart failure a progressive disease. The body thinks it's bleeding out, basically. It thinks it's in shock.
And its only goal is to keep blood pressure up.
Right. And since BP equals cardiac output times systemic vascular resistance, if SCIO drops, the body panics and just slams the accelerator on SVR. It constricts everything.
And it does that with the sympathetic nervous system first, right? The adrenaline response.
The immediate fight or flight. Baroreceptors sense the low flow and bumeapinephrine, norepinephrine everywhere.
What does that do?
Two things. It increases heart rate, which seems good, but critically, it causes massive vasoconstriction through alpha-1 receptors. It just jacks up SVR, the afterload.
And if we connect that back, for the diastolic stiff heart, more afterload means it has to work even harder.
Which triggers more thickening, more hypertrophy. It makes the filling problem worse.
It's a doom loop.
And for the weak, systolic heart.
It's just as bad. The SNS also squeezes the veins, pushing more blood back to the heart. That increases preload. For that already overstretched weak ventricle, more volume just makes it dilate even more.
But wait a minute, these systems are for survival. If we just block this fight or flight response, what are the risks? Can't the patient just crash?
That is the tightrope we walk. You're exactly right. If we block the SNS too hard when a patient is in crisis, their blood pressure will plummet. That's why beta blockers, which do exactly that, are only started when a patient is stable and their fluid is under control.
And that's just one system. What's the other big one?
The other is the renin-angiotensin-aldosterone system, the
Mm.
RAAS. Okay, so the kidneys sense low blood flow and they freak out too.
They think the body is dehydrated, so they release renin, which starts a cascade. Renin becomes angiotensin the first, then angiotensin the second.
And angiotensin the second is nasty stuff in this context.
It does two terrible things. First, it's a crazy powerful vasoconstrictor, so again, more afterload. Second, it tells the body to release aldosterone and ADH
So the body starts hoarding salt and water.
actively. And all that retained fluid, the edema, just massively increases the preload, the volume in that struggling heart. It makes the HFrEF heart stretch even more, and it's why patients get so wet and congested.
Wow. So the backup, the congestion we see, is literally caused by the body's own failed attempt to fix the problem.
That's it in a nutshell, and that wetness is where all the major complications come from.
Okay, so let's talk about where that fluid backs up. For left heart failure, the backup is behind it, in the lungs.
Exactly.
Yeah.
Primary congestion. The pressure builds in the pulmonary capillaries. We measure this as the pulmonary capillary wedge pressure, or PCWP.
And when that gets too high,
The fluid just gets squeezed out of the blood vessels and floods the air sacs. Pulmonary edema.
and that's what causes the symptoms, right? The shortness of breath.
That's the dyspnea, but also the classic ones like orthopnea. You can't breathe when you lie flat. And paroxysmal nocturnal dyspnea, where you wake up gasping for air.
Okay, so that's the left side. What about right heart failure? Where does that blood back up?
It backs up into the whole systemic circulation, into the body, through the vena cava. We call this systemic congestion.
And you can actually see this one on the outside.
Oh, yeah. You'll see jugular venous distension, the JVD, in the neck. You'll see pitting edema in the legs. And if it's really bad, it backs up into the liver, causing hepatic congestion and can even push fluid into the abdomen. That's ascites.
And when all of this just fails catastrophically, you end up in cardiogenic shock.
That's the end stage. The cardiac output drops so low that organs just aren't getting perfused. The body's last-ditch effort is that reflexive vasoconstriction, which is why patients in shock have cold, pale extremities.
But the real damage is internal.
The brain doesn't get oxygen. You get encephalopathy. The kidneys shut down. You get acute kidney injury or cardiorenal syndrome. It's a total system collapse.
And you mentioned a really scary mechanism with right-sided failure specifically.
Yes. If the right ventricle fails and dilates massively, it can physically push the wall it shares with the left ventricle, the septum, over into the left side.
Septal shift.
And that crushes the left ventricle's filling space.
Yeah.
So even if the left side is healthy, it gets no blood to pump. The result is immediate, profound shock.
Okay, we have to touch on the paradox before we get to treatment. High output heart failure. How is that even possible? How can you fail if your output is high?
It sounds impossible, right? But it goes back to that equation. BP equals COX SVR. In this case, the heart is fine, but the SVR, the systemic resistance, is just plummeted. Massive vasodilation.
So the pipes are wide open all over the body.
Exactly. And to maintain any blood pressure, the body drives the cardiac output sky high. But even though the CO is high, it's still not high enough to meet the tissue's oxygen demands because the blood is flowing so fast and the pressure is so low, it's failure relative to demand.
And what would cause that kind of massive vasodilation?
The classic cause is sepsis, but also things like severe anemia, thyrotoxicosis, an overactive thyroid, or even a severe thiamine deficiency, which is beriberi.
Fascinating. So let's pivot to the clinic. How do you sort all this out and actually make a diagnosis?
It's a multi-tool approach. A chest x-ray can show us if the heart is enlarged or if there's fluid in the lungs. We use a blood test for BMP in the ER to see if the heart is being stretched by fluid.
But to really know if it's the weak balloon or the stiff bunker, HFrEF or HFpEF.
For that, the echocardiogram is the gold standard. It gives us a live look at the heart and tells us that all-important ejection fraction, that number dictates everything.
And in the ICU for an acute crisis?
We might use a right heart catheter, a Swan-Ganz, to directly measure that pulmonary capillary wedge pressure. If it's over 18, we know for sure there's acute fluid backup from the left heart.
Which brings us to treatment. And for chronic HFrEF, it seems the entire philosophy shifted once we realized the SNS and RAAS were the enemy.
Completely. Guideline-directed medical therapy, GDMT, isn't about symptoms. It's about reducing mortality by blocking that neurohormonal death spiral. We talk about the 4 pillars.
Pillar 1.
The ARNIs, angiotensin receptor neprilysin inhibitors. The main one is sacubitril/valsartan. This is now preferred over older ACE inhibitors because it showed a huge benefit, about a 20% reduction in cardiovascular death.
But there's a big safety warning when switching a patient to an ARNI, isn't there?
A critical one. You must have a 36-hour washout period after stopping an ACE inhibitor. If you don't, you risk life-threatening swelling called angioedema. It's non-negotiable.
Okay, pillar 2, beta blockers, blocking that adrenaline overdrive.
Crucial. They reduce mortality by about 35%. But, and this is key, only 3 have proven benefit: carvedilol, metoprolol succinate, and bisoprolol. Using the wrong one is a mistake.
And pillar 3 is the newcomer, right? The SGLT2 inhibitors.
It's a game changer. Drugs like dapagliflozin, we use them for diabetes, but they show this incredible ability to reduce heart failure hospitalizations and death.
Even in patients without diabetes.
That's the amazing part. The benefit is there regardless of diabetes status. They are truly cardioprotective.
And the final pillar, number 4.
The mineralocorticoid receptor antagonists, MRAs, like spironolactone, they block aldosterone, stopping that salt and water retention. Together, these 4 pillars are the foundation.
And diuretics are just for symptoms.
Just for symptoms, they get the fluid off, make you feel better, but they don't have a mortality benefit like the 4 pillars do.
Okay, let's switch to the acute setting. The patient is crashing. Acute decompensated heart failure. You have a simple framework for this.
It's all about wet versus cold.
Okay.
Are they congested or are they poorly perfused?
If they're wet, meaning congested.
We hit them with IV loop diuretics, hard and fast. If their blood pressure is okay, say above 90 systolic, we can also add IV vasodilators like nitroglycerin to rapidly reduce the pressure on the heart.
But if they're cold, meaning their blood pressure is already low.
Then you can't use vasodilators. That's when you need IV inotropes like dobutamine or milrinone to actually boost the heart's contractility. It's a rescue therapy, though. They can increase mortality long term.
And there's one non-drug intervention for that wet patient struggling to breathe.
BiPAP, bilevel positive airway pressure. The mask provides pressure that essentially keeps fluid out of the lungs and makes it easier for the heart to pump. It can work wonders very quickly.
We have covered so much ground. So to recap, we started with the difference between HFrEF, the weak dilated pump.
And HFpEF, the stiff filling restricted pump.
We saw how the body's own survival instincts, the SNS and RAAS systems, actually drive the disease forward.
Creating that vicious cycle.
And then we detailed the modern 4-pillar approach designed specifically to block that self-sabotage and improve long-term survival.
Which leads us right to our final thought. The entire modern management of this disease is based on overriding the body's most basic, evolutionarily honed survival signals. The instinct to raise blood pressure and hold on to fluid is, in this case, catastrophically wrong.
So the provocative thought for you is this. How does that idea that we treat a chronic disease by aggressively blocking innate survival pathways change how you think about other chronic conditions? What else might your body be doing for short-term survival that could be fueling a long-term problem? That's